our slides. Actually, do I see Leslie Clark here from, I see Catherine from Portland Recovery. Well, hopefully we'll get there. All right, reminder, closed captions are available. They work really well on Zoom. If anybody needs to get more guidance on them, please ask in the chat. Oh, look, I can already see it on my screen. Hopefully you guys can as well. And then Ellie and Cora can help you out behind the scenes. Did we hit record?
Yep.
And can we do a mute again for Brigitte because we have back feed? Here we go. Perfect. All right, next slide. So just as a reminder, this is a funded initiative from the National Institute on Drug Abuse to advance the science on recovery community centers. Our goal is to bring together the different key stakeholder groups in building that science together, which is clearly not just scientists, but includes people who are actually leading recovery community centers, the people who go to recovery community centers, clinicians, policymakers, the public, everybody who's involved. Here's the steering committee that kind of discusses behind the scenes about the topics of seminars and who's guided our pilot study project in terms of what are the important topics that need to be studied and how to support them. So acknowledgements to them. Next slide. And then we also want to make sure that we always mention the Consortium on Addiction Recovery Science. Our project that focuses on recovery community centers was one of 5 that were funded at the same time by NIDA to really advance the science on peer recovery support services and recovery science. And after funding, the 5 teams banded together to create the Consortium on Addiction Recovery Science. We just had the conference that they host in the last 2 days, which is why many of us are exhausted and not currently in the Zoom room like we usually do. But this is the current updates from a larger consortium, and we will send out the slides so you can actually click on the links and read this in more detail as you go along. Next slide. All right, we do have a list that we maintain of RCCs for people who are new to RCCs. They get excited when they hear about all the wonderful work RCCs do, and they ask us, do I have an RCC near me? And for that purpose, we're maintaining a list as best we can. So if you know of an RCC that is not currently on our list, we would love it if you could let us know. And I think, Ellie, you already posted that link to the list. Perfect. There she is. Thank you, Ellie. So if you just want to take a peek there in your state to see if you've got everybody that you know about on that list, that'd be great. And then, of course, for research initiatives, we also reach out and saying, hey, I have this topic area. Can we reach out? And that's totally fine. You can go to the next slide. All right, for our live feature, and we will also have a video later on our website as well, so people do look at those later on too. I'm very, very happy to have STEPRox here with us. Nathan, Lorraine, and Loretta, I think you have prepared a video and slides. So if you want to go ahead, the goal is always to ground us in what is a recovery community center. And every RCC looks different and a lot of things are shared. So we are always happy to have a different feature each seminar to ground us in what it is that you do. So what happens when you walk through the door of STEPRox?
If you can hold off on the video until Loretta has introduced, that will and play that as I give you a virtual walkthrough of the center, that would be great.
Works.
Well, so hi everyone. My name is Loretta Leverett, and I am the director of STEPRox Recovery Support Center in Roxbury, Massachusetts. And we are also a program of North Suffolk Community Services. And we are very excited to be here today and to give you a 4-minute tour of what it's like to come to our center. And I'm also a woman in long-term recovery. So I can remember how it felt to seek recovery services and to go to a place where I was unfamiliar. It's my early recovery, and I was anxious and nervous. And so one of the things we thought about in the design of our center is to set it up that so that even from the street, you can look into our entryway and that you might see a scene that would make you feel more relaxed and comfortable to walk into our center. And so that's what we did. So just to set it up, you'll see the slide, but I just want to set it up a little bit to give you the flavor of what it feels like. And what we've been told by our members that it feels like when they first came to our center. So in our entryway, we have 2 high back easy chairs that flank a bamboo and glass table that has a light at the base of it. It's a beautiful glow. And so when people walk by our center, that's what they see. On the top of that table is a beautiful vase with a bamboo plant. And we've been told that bamboo represents well-being and positivity. So that peaceful scene can be observed from the street, and it's designed to be welcoming, lessen anxiety, and promote a sense of safety. And I think that you'll see what I mean when you see the slides. And maybe even though you're on Zoom, and maybe if today you're feeling a little anxious, that maybe just by seeing that particular tableau, that you'll feel less anxious. So I'm going to pass it on to Nathan, and he's going to walk you through.
All right, if you could begin the slide presentation. My name is Nathan Miksch. I am the Assistant Director of STEPRox Recovery Support Center. The response that's most often elicited from newcomers to STEPRox is something along the lines of, "Oh, it's so nice in here." That's not an accident. STEPRox was designed to feel like a homey, welcoming space that provides a sense of comfort and peace to anyone who walks through the door. Looking around, visitors are met with messages of hope and encouragement on the walls and on the tables scattered around, as well as information about events and resources that might be of interest to the community. After being initially greeted, either by a volunteer at the front desk or a staff person, newcomers are introduced to any other staff present that day and given a brief explanation of what that person's function within the center is. Then someone sits with them one-on-one to get a sense of what that person's needs might be and explains what STEPRox is, what we are not, what we have to offer, and what the benefits of membership might be for anyone interested in signing up with us. And all of this is done without urgency, without pressure. We want to meet people where they are. We want to provide a safe, welcoming space for them and make sure that we are doing the best that we can to figure out what their needs are and to meet those needs. And with that, I will pass it on to Lorraine, who will talk about her own experience coming to STEPRox in the early days. I think you're muted, sweetheart.
Thank you. Thank you, Nathan, and good afternoon, everyone. My name is Lorraine Barton. I have been a recovery coach and certified peer specialist at STEPRox for almost 10 years now. It is my pleasure to speak to you today of the significant impact that STEPRox has had in my life as a member and a coach. First, know that I found STEPRox at a very dark time in my life. Although I wasn't using, I also wasn't recovering. More to the fact, I was isolating and declining. STEPRox was then and is now a very welcoming place. And that's what I felt the first time I went. I felt welcomed. Almost immediately, I felt a sense of belonging, and I became a member and actively got very involved in the volunteer works. Before long, I was trained and employed as a coach, and my self-esteem returned. STEPRox helped me to get back in touch with me in my recovery. I try to offer what I received, and that was empathy, respect, and understanding. And I try to offer it to those who come in. Honestly, all of us, our volunteers, our staff, we all take the opportunity to welcome people as they come in, especially the new faces. It is our hope that they see friendly faces in a beautiful, welcoming environment as they walk into our space. If someone is looking for a coach, I usually bring them into my office, which I intently try to keep bright and inviting. The first meeting is often casual. I want them to meet Lorraine, the person, not someone who is pushing papers and asking a lot of questions, just Lorraine. I encourage them to talk. It is my hope to help them relax, to see me as a peer, and feel good about their decision to walk in that door. Hopefully, a good impression is left, and they leave with another appointment in their hand and a real interest in returning. Thank you.
This is perfect. Thank you, guys. We're going to be using this a lot for introducing people to recovery community centers. All right, Leslie Clark, are you here to tell us a little about this announcement here? Okay, so, and I think we have it on the website too. So we have, we just want to share that the Portland Recovery Community Center is looking to fill a position in their organization. And since you all know people who have the skill sets and who have interest, we wanted to ask if you wanted to spread this in your professional networks to help them recruit for their position. And we have Allie just shared the PDF for the for the position announcement, and we'll also put it on our website. So if we could help the Portland Recovery Community Center spread the word for this position, that would be lovely. All right, now we will do our polling questions to get us ready for the presentation to come and to get us going on the topics. We'll start with the demographics as usual, and then we have 2 questions about the content of the presentation to come. As usual, just fill in the answers, and then use the little gray tab on the right-hand side to scroll you down. When you are done, the submit button should turn blue, and you can click it to finish it. All right, Liv, how are we looking for completion?
70%.
I'm sorry, what?
70%. We're actually now at 76, but we're almost at 80.
All right, so 2 more and we'll be at 80.
Just hit 80.
Beautiful. Anybody want more time? Happy to wait if somebody wants more time.
I think we're getting ahead now, so I'll hold off.
Since we are a very small group, we can wait for each one of us.
Okay, we're almost at 100%. I think literally might be the last person because I don't fill these out.
Oh, do it so we can hit one. Do it. It'll be the first time we'll have 100%.
Anyone need more time? I think we're all set. Okay.
All right, so here we go. So if I scroll us down, so we have scientists and RCC folks here in the most represented groups today. And if I scroll down to the questions that you will hear lots of information about in a moment, we had one question comparing to a survey that was a long time ago for behavioral health professionals, survey 20 years ago. how satisfied are RCC, how well are RCC staff doing regarding these particular issues. And most people thought that they're probably doing better in terms of satisfaction with available resources and confidence in their ability to fulfill their job. And only a couple of us thought that they would also be doing better regarding stress and burnout. And the correct answer is all of them except burnout, which wasn't directly assessed. And you will see those data in a little while when Craig and Angela share those. Then in terms of this one, when you're comparing people who are working at RCCs to people who are peers working in other settings, and they were surveyed about 2 years ago, which of these tasks do RCC staff do more than their peers who are employed in other settings? And here we have a large number of different things. And most of us thought that help establish recovery goals would be the thing that they do more. That's the top runner. And I see serving as a role model and share recovery stories. And it's actually those two. It's the help establish recovery goals and help meet basic needs. But again, you will see what we mean by that when Greg and Angela tell us more about it. So great to see your initial thoughts. I'm curious to see as we're discussing this, what made you click one box versus the other. All right. If you want to go on to the next slide. As always, what we're going to do is we're going to have our presenters present first, and then following their presentation, we're going to have our discussant, we'll get to in a moment, to do a 5-minute summary. So Craig Henderson and Angela Hagaman were funded by the pilot study program that we have for this R24 funded by NIDA. You've heard them announce their program, their study a while ago, and here we are with the results. And if you just want to give us the next slide so we can see who the discussant is. Oh, we don't have Adrienne's slide?
It's not the next slide, it's the slide after they present. So
oh, very good. So after they present, Adrienne Lapidos will be sharing her perspective with us. And of course, we invite everybody to jump into the discussion. There's lots of rich discussion points here. So Craig and Angela, take it away.
All right, thank you so much. And Loretta, Nathan, Lorraine, thank you for the glimpse you gave us into your recovery community care center. Not to throw away the punchline too early, but I found it really interesting that the care that you have taken to make it a welcoming environment. Other RCCs are following that example. And we have a little bit to share about that in the research we're going to share with you. As Bettina mentioned, I'm Craig Henderson and joined today with Dr. Angela Hagaman. And our project is on assessing the recovery community center workforce in rural and urban settings. One thing I want to say off the top is we are part of the way through, and we're rejoicing when we heard that MGH got a year extension so that we could continue this work. So what we're presenting today is from 6 of our projected 10 centers, but it's looking very positively like we will be able to have all 10, and perhaps we'll get an invite back to share with you at that point. Next slide.
I'd be very happy to do that.
Thank you, Bettina. Next slide, please. So definitely want to mention 2 other team members who have been critical to this work. Ruthie Miller is a PhD student at Sam Houston State University, and Hannah Warren is also a PhD student in public health at East Tennessee State University. And I think Hannah's with us today. So hi, Hannah. Next slide, please. Okay, so we had 3 aims. The first was assessing staff background and training, and as well their subjective experiences regarding job satisfaction and self-efficacy. We used a mixed methods research design, so we're going to share some data that comes from a quantitative survey and then some from a qualitative focus group aspect of the study. So we're very pleased that the the quantitative and the qualitative data are meshing together fairly nicely, which doesn't always happen. We are providing incentives for people to participate. So we're providing $500 for the RCC itself. And then those who participate in the focus group, 25, and the survey, which takes about 20, maybe a little longer minutes to complete, $10. Oh, one thing, and we haven't gotten this far yet in our analyses, but we are taking care, we're randomly selecting from the uh, list that Bettina, Olivia, and others have put together at MGH and supplemented with a few additional that we were able to find. And we're randomly selecting from those lists from 5 different geographic locations. And from each of those locations, a rural and a urban RCC. So we're hoping to have some comparisons between the rural and urban, as well as what's going on in different geographic regions throughout the country. Next slide. Our second aim is to identify the most common services, which you got a preview of in the polling questions. I mentioned the quantitative and qualitative aspects. One thing also we're looking to dig into a little more is a little more specifics in terms of how these RCC workers are creating these linkages within these recovery ecosystems. Next slide. And the third, we haven't got here yet, but we're going to look, we will be doing this over the next year, look at relationships between staff characteristics such as employment. We have a number of people who are paid staff and some who are volunteers. Where we have information on certification and training, and we'll look to see how these are related to the different outcomes you see with the bullets on the right-hand panel of this slide. We're also going to look to see if those relationships are influenced by recovery capital, the self-assessed recovery capital. Next slide. Okay, so as you all know, RCCs have been characterized as a new kid on the block, really up and coming, doing very important work, but at this point, relatively understudied. You don't need me to tell you about RCCs. I think you all know much more than I do, but I'm learning a lot, and I'm grateful for the opportunity to do so. The aim of our project is to focus on the workers, both paid staff and volunteers who are working in these centers, as opposed to the people receiving services themselves and their outcomes. Next slide. Okay, so the first part that we'll talk about is the quantitative survey. So this was done online. If you all are familiar with Qualtrics, it's a survey development tool. And we collected information. Angela Hagaman led a study that was published earlier this year. And so we adapted some questions from that. And you'll see a lot of comparisons with looking at the second set of bullets there, the TCU survey of organizational functioning. This was a very helpful survey that shows how workers are feeling about the settings in which they're working. Next slide, please. Okay, so in terms of our quantitative survey, so far, I mentioned that we have gotten data from people at 6 RCCs. Those comprise 37 staff, both paid and volunteer, and our response rate is just under 51%, which we're really pleased with because this type of survey, this is a really high response rate for comparatively speaking. You see a little bit about the demographics. One thing I want to mention is about 62% are in recovery themselves for either substance use or substance use and mental health. And oh, I just see a question here. What recovery capital? It's the brief, the BARC, brief assessment of recovery capital. Do I have that right?
Yeah, the BARC 10. And you can also find it on our website. Ellie just put the link in here for the repository of useful skills. If you want to go there, click on BARC 10, you'll see the items. Sorry, Craig?
I think he might be frozen.
You jinxed it?
Yeah.
Uh-oh. I can tag in. Needed. We'll give him a second to maybe rejoin. Darn alien sign.
Indeed, indeed.
Yes, certainly. So he was talking a little bit about the response rate and the demographics of those that have responded thus far to the quantitative online survey. And so you can see here what those demographic categories were, more male, and you can sort of see the different ethnic and racial breakdowns of those that responded, and those that said they were in dual recovery, both mental health or substance use disorder, is often more frequently associated with the peer recovery workforce, and 2.6 were in other mental health recovery. So the average time in recovery for these respondents was 11.2 years. Okay, you can go to the next slide. I certainly don't want to steal his thunder here.
I am back. I am so
Yay.
sorry.
Yay.
Our university has put it's our computer overlords, but I'm very sorry for the interruption there.
I thought that jinxed you, Craig, so I apologize for that.
Oh, no, I don't think so. All right, so I had mentioned the survey of organizational functioning earlier. Okay, so something about that. The study that was conducted in 2004, it was conducted by researchers at TCU Institute for Behavioral Research. If you look at the right two columns, this comprises that sample. So this was a sample of community-based substance use treatment providers. So this is a different type of sample. Another thing to keep in mind is this study was done about 20 years ago, but this is the sample they used to develop the instrument. Then looking at the second and third column, these are the responses, the average responses that we got from participants in the current study. So all of these folks are working in recovery community care centers. The pattern of results are showing that in terms of the resources, how well they are perceived, the resources they have access to is significantly higher than those in the original sample. Now, some of these things, mind you, this is 20 years later. And so some of these things like computer access and electronic communication, you would expect would improve over time and more access and people's familiarity. But we also see this with office space, staffing, and training. In terms of motivation for change, this is perceptions of needs. And here, lower scores actually reflect more favorable outcomes. And so these people are seeing fewer needs for improvement, fewer needs for training, a perception of they're receiving the training they need. Efficacy is scaled the other way. So these people are seeing they're more efficacious in the jobs that they're doing. And burnout, as Bettina mentioned earlier, there's no direct comparison, but looking at like the average scores, this is a lower burnout than you would anticipate if everyone just like selected the middle response. All right, so next slide, please. So from Dr. Hagaman's survey, there was we assessed the frequency that individuals were conducting several different activities. On the far right panel or column, those are results from a 9-state survey of community peer workers in a variety of settings. The middle column then represents the current sample. The gray boxes are showing what was common in terms of the top activities selected in both samples. So we're seeing a high level of particularly the providing emotional support. And this is what Angela and I have talked about getting into even deeper, is what is happening with this emotional support. Things that are happening uniquely with the RCC sample or a uniquely high rate are helping those establish those recovery goals and helping meet basic needs. Next slide, please. Okay, so I'm now passing it off to the very capable hands of, actually very capable, like I'm riding Angela's coattails to be perfectly honest. And so we'll hear from her now.
Not true, not true at all. It's been great to partner with you, Craig, and Hannah and Ruthie. It's really been so wonderful to learn more about recovery community centers. And sort of as a reminder, we were really interested in understanding the peer staff, those paid and volunteers working in recovery community centers. So my work prior to this has been understanding the peer recovery support specialist workforce as a whole and what they are doing. And so that previous work that we did really asked peers in general at different organizations what work they did within a recovery community, recovery ecosystem, and what activities. So those top activities, it was great to see that there was some commonality, but also really interesting to begin to understand what is unique about the workforce at a recovery community center as opposed to peers working in other settings across a recovery service network. So with the focus groups we've conducted, you'll see the preliminary data from the first 6 focus groups, and we had 22 folks participate, and that would be 45% response rate. So of those asked, about half participated, and we did cap that at 8, and we did have one focus group that was full. So these are the breakdowns, the demographics of those that participated in the survey. And they had a little bit longer time in recovery at 15.3 years, and also dual recovery, some in recovery from SUD only, and 4.5% in mental health only. So it's a variety of personal experience, personal recovery experience. Okay, next slide. So our qualitative analysis was a deductive analysis. We had predefined categories that were similar to those that were in the survey of organizational functioning and those constructs that you learned from Craig about the different survey constructs. So we asked them, generally the constructs were, who are you and how did you find your way to a recovery community center to work there? What is it like to work at the recovery community center? What kind of training did you get? What work activities do you do? And then tell us a little bit about the participants that you work with. And so those, you can see some of those themes here that we're beginning to analyze. We utilized a radar technique, which was a rapid or expedited analysis. And then once we had those themes ready, then we met with Craig and Ruthie and looked at the results of their quantitative survey to see where we were in agreement or maybe where there was conflict. So far, there's been a lot of agreement, which is pretty exciting. It's also exciting when you have conflict because then you sort of have to dig in and understand that a little bit when you triangulate the data. But some of the things we're seeing here is that the major themes for the participants are they come in with a high level of acuity, meaning there's a lot of crisis, there's a lot of acute needs. And so we're beginning to understand that the reason that maybe the top 6 activities, those 2 that were sort of statistically different than a broader peer sample, was that when folks are coming into this low threshold service, they might not have a place to stay. They might be in crisis. They might not have their ID. So there's a high level of acuity. And you can see there's a quote here. I feel like a lot of people come in and the fire is blazing all around them. It's just like, okay, we're going to sit down and see what we can figure out. Because usually people are in pretty hard spots, whether it's experiencing homelessness or being in a lot of legal trouble or just the situation where I came from from into recovery where everything was terrible. So we're seeing that there's a high level of acuity. And then when we talk about the staff themselves, I would say that I came into this with an expectation that there would be a high level of stress, a high level of burnout, that dealing with this level of acuity would be super challenging for the RCC staff. But what we're hearing is that their team-based approach, the fact that they're working together, and we heard that a little bit from STEPRox, that sort of they're working together, they're meeting different people, that they feel like they're each bringing their own personality and strengths to the table. It says, then as we work together, we tend to find out who may be able to bring a benefit to the peer over here, or who can help out better over there, and where we can all come together and actually be able to help people. So that team-based approach is really showing up in our data. And then again, the physical space, homey comes up over and over and over again. So it was so great to see those pictures. Nothing, you can see the quote here, nothing is extravagant here when you walk in. You feel welcome. It's homey. It's not clinical. It feels like you're walking into someone's home. And I think that's a really important ingredient in the RCC space. All right, so next slide. And so data triangulation is where we're looking at the themes that we're finding in the qualitative analysis, these focus groups with actual RCC staff and the results of the survey that they took. And so these are the things, and you saw some of that in the images, but essentially we're seeing that a lot of the participants that come in have few resources and complex needs, and that these are corroborating some of the quantitative findings of activities that they're doing most often. And then when we see that the RCC staff have a high level of self-efficacy and positive perceptions of their organization, we're hearing that in the focus groups as well. We don't hear that they're feeling super stressed out and that they're overwhelmed. We hear that they're getting all of the training that they need, and that when they need a new training, say trauma-informed care or human trafficking, they're able to access that pretty readily. So we were excited to hear that. And that when they don't know what to do with a client presentation, and these are called peers. They're not often called clients, they're called peers. And so that was a little tricky as we were trying to figure out who the peer was, but we love that that was non-hierarchical. And we think that that's going to be an important finding also when we finalize our data analyses. But they're leaning on each other. It's a team-based approach. And then again, the physical spaces, they're saying they have the space they need. They have the office space they need, private spaces, public spaces, and they're very homey and non-institutional, so people keep coming back. So that's sort of some of the initial triangulation that we're finding in these data. And then the next slide. And so again, some of those other overarching themes you saw from our initial aims, we wanted to understand linkages to care in the recovery ecosystem. How do RCCs accept referrals and make referrals to other agencies? And then we did ask about joys and challenges, like what's the best part, what's the hardest part? So you can see some initial data findings here. We find that all of the RCCs accept referrals from multiple external partners, and they refer to multiple external partners. So there's a lot of interconnectivity within the service network. They have strong connections with the criminal legal system. So a lot of them are really involved in drug courts, and that's the terms that they used. And jails, many go into jails and then refer folks directly when they leave, leave the jail, they're able to come directly to the RCC, and some of them even pick them up. So that was pretty exciting to hear. They often offer staff classes and mobile recovery coaching, so everything isn't happening within the confines of the brick and mortar RCC. 4 RCCs were standalone RCCs, others were embedded in larger recovery community organizations, and it seemed that those embedded in larger RCOs had other grants to deliver Narcan training and things like that. And often the rural RCCs seem to provide more transportation, and that kind of makes sense, but I was glad that that was a service. When they talked about joys, just seeing the client's success, the other peers succeed, was really rewarding to staff and helped their own recovery. He said, seeing the generational dysfunction, generational domestic violence and abuse, generational undiagnosed mental health, and seeing those chains broken, those processes interrupted, to me, that's amazing. That was one of the quotes. And the other quote was, you'll see these folks come in all beat down, just like I was, then start having the light come back on in their eyes and start healing from some of the worst stuff you could ever imagine. And then the challenges over and over, we're hearing that housing, finding stable housing just comes up over and over. And the lack of resources, and still RCCs are playing a big role in fighting stigma in the community. So two quotes that I think are really powerful here, and then I'll close. The amount of time it takes to navigate systems and hoping you can get far enough, fast enough to keep a person motivated and see results before they feel like they're struggling so much that they revert back to their past coping mechanisms. And then another quote, housing is horrible. Getting into treatment programs, there aren't enough beds available and they're expensive. So they're able to meet their needs in the RCC, but sometimes the referral process can be really challenging. All right, next slide. And so some preliminary conclusions from these first 6 RCCs and the data we've collected is that overall the staff report high levels of satisfaction, including with respect to their training and their physical workspaces. They describe a strong sense of self-efficacy and relatively low stress associated with peer work, alongside efficacy in maintaining their personal recovery. So we heard good stories of how this was helpful to the recovery, and when something came up, they were able to rely on the team to manage and maintain their own recovery. So our next steps is to continue the qualitative and quantitative data collection at the remaining 4 RCCs. We're happy to say we have 3 of them with MOUs and 1 of them with a scheduled focus group next week. And so we'll continue that and be able to have our final results and additional products, posters, presentations, papers. Hopefully all of that we'll be able to share with all of you. I think the next slide is our funding statement. There you go. And Bettina is the PI and talked a little bit about the overall study. And then now we're, I guess, open for questions that you might have.
Wonderful.
Yeah, I will say these are some of the questions. We won't say what questions you need to ask, but we are interested in your thoughts on how best to proceed. You've seen sort of what we're looking at so far. So if you have any tips on the data triangulation or how to present some of these findings in a better way, we're open to that. And any thoughts on how to frame manuscripts. So there's some questions we might have if you don't have any.
Oh, I'm sure we'll have questions.
Yeah.
I also want to, I already see Keisha's and Robert's comments in the chat here, which we will absolutely get to. I was going to first give Adrienne a chance to chime in from her perspective. Adrienne, can you comment from your perspective about how this research fits into what you know about the space and the kind of research that you have been doing?
I would love to do that. Thank you. And thank you so much for a very interesting presentation. This work is just so valuable and so community oriented. And I love the partnerships that you developed in the way that you're really shedding light on kind of like a hidden gem, really a gem in our communities that really need more attention and more light shed on the valuable work that you do. So I was very interested in a couple of elements of what you were talking about. One, and I was taking notes here, like the finding that within the recovery centers, you were expecting perhaps to see a lot of burnout or a lot of dissatisfaction, or perhaps it would be natural to expect something like that, and that was not the case. And that really meshes with my previous experiences in research and community-based practice too. Like I think that people go into this field because they want to do hard things. There's nobody who signs up to do this because they don't want to do hard things. They want to do hard things. So burnout is not so much a function of work being too hard for people. I think burnout comes from systems problems. When people feel like they're being thwarted in doing the hard work that they want to be doing by the system that surrounds them. And so that's where we really see kind of mismatches, where perhaps a system is overly clinical and the peer supporters are attempted to do something that's related to recovery that perhaps can't be framed in clinical terms. Or perhaps things like inadequate supervision, where people feel like they're not supported within the system, or they feel like the system doesn't really understand the peer role and doesn't value it sufficiently. And when people are feeling undervalued for the hard work that they're doing, that's when we can really see burnout becoming a problem. So I think your results around burnout and job satisfaction kind of make a lot of sense if people are nested within the very difficult work that they're doing in an environment that really validates and supports that work. So that was one thought. Another one is I'm very interested in what you were talking about, where people arrive and it seems like everything is on fire. There's just lots of different problems. And I just finished participating in a 5-year study on peer specialists who were doing suicide prevention roles and having really, really difficult conversations with people specifically about suicide. And again, what was interesting about this study was that the peer specialists and peer recovery coaches did an incredible job having deep, meaningful conversations with people about suicide. We had systems in place to support them in crisis intervention and clinical backup when it was needed, but we were encouraging those conversations. We wanted them to happen. Whereas in other systems, when we did qualitative research to better understand suicide prevention roles with peers and peer recovery coaches, what was found was that sometimes the protocols would actually get in the way. It was almost like a freeze effect. Like the word suicide was brought up, and all of a sudden it was like, oh no, I can't have this conversation. I'm not supposed to have this conversation. I need to follow my standard operating procedures and get a supervisor. And in a sense, like those conversations can be chilled by those systems. We think that those conversations can take place very effectively. And it's a question of people feeling like they have the right training and the right supports to have those difficult conversations in moments of crisis. I wanted to mention one other thing I have in my notes here. Oh, that specifically what research shows predicting job satisfaction. One of them was mentoring from supervisors, another was recovery-oriented workplace and role clarity. And I think that's kind of interesting when it kind of meshes with the findings that you had. And from a peer survey that my colleagues and I did, this was pre-COVID, it was like 2018. We found financial fragility was an issue with people working in the peer space. So a very high proportion of our respondents were saying that the wages that they were receiving were not sufficient to prevent them from being financially fragile. And the way we defined that was, could you withstand a financial shock of a $3,000 expense? And we got that number from basically an economist who did some research about common financial shocks. And she basically conceptualized this $3,000 number as something that's like a major car repair, for example, that could happen to anyone. And what we found was a lot of the peer specialists that we surveyed, unfortunately, felt that they were financially fragile. And what that means to the workforce. Are we truly valuing this workforce by providing a living wage? And that then will go into kind of the future of the workforce. Are we creating systems that will truly support the workforce in a career ladder, but also, being able to have enough financial security to function well, both at home and at work? That is all I have. Thank you again for inviting me here. This was a really fascinating presentation, both from the recovery community presenters too. I really loved seeing those really homey pictures of your center, and I only wish we could send people your way from Michigan, because I have lots of people I serve as a psychologist who I think would really value that space.
That's wonderful, Adrienne. I love it. Yes, the intro of STEPRox for this was just perfect. It couldn't have been dovetailed better. I'm super excited about this paper coming out in the empirical literature soon. As soon as you guys are done data collecting, of course, Angela and Craig, because it's so important. The topics that you're highlighting here for people to grapple about the unique space of the RCC, the teamwork, and all these other things that you're highlighting. Let me jump over to the questions in the chat. I wonder if you guys have already seen it. I was going to scroll up and start with, I think it was Keith who had the first question. I don't know if you want to say it yourself or if you would like me to read it for you.
Hey, Bettina and all. Thank you so much for this presentation. I did have a question about the challenges you mentioned around housing. And has the RCC considered other strategies to addressing those challenges beyond referrals?
And I can go ahead and jump in just from, the conversations that we're having in the focus groups. It's not a question that we're asking, right? So we're asking some, what do you do on a daily basis? So it came up and we really didn't go down that route. What are you doing differently? But I will say that you could hear stories of how they were creating service lists. So many in the rural communities have these very detailed service lists, and we're making friends with, first name basis with, the few housing providers that were there. So they know them. When they pick up the phone, they'll say, "Oh, yeah, it's you again." And so they were building relationships so that they would know and could maybe more readily find the right placement for someone. There wasn't, at least two of them in the bigger organizations had housing available as a part of their larger agency. So I think that sometimes when RCCs are in larger RCOs, they're able to meet that need. And then some of them were talking about new grants, but we didn't ask the specific question, what strategies are you doing to reduce these challenges? But I can just, from memory of all of the data that I've been diving into and the time spent in those 90-minute focus groups, they really are trying to find the workarounds. And sometimes they can't. Yeah.
Loretta, Nathan, how's it look like for you guys? Referral is what you can do, and what does it look like for recovery housing in Massachusetts? Do you know? And Julia, maybe you can jump in for this too.
Sorry, I didn't. Go ahead.
I was just going to say that we're in Boston, and housing is an issue for everyone. So it's that's an ongoing problem all the way across the board. Even I'm having trouble with housing, and it's just expensive out there. There are no real answers in Boston right now. We can make referrals to places, but people end up on waiting lists for months and sometimes longer. And it doesn't look like it's got a problem that's going to be solved anytime soon. There's just a lack of housing, and because of that lack of housing, the housing that's available is astronomically expensive. It's just it's a huge issue in this area.
Let me say this, and I'm sure many people are experiencing this, but as Nathan says, it is a huge, huge problem here and everywhere. But Boston, as he said, is extremely expensive. But hear this part. When you are suffering with substance use disorder, maybe you don't have your children. Maybe because you don't have a place to live, you can't wash. You can't wash your clothes. You can't present an employable face to someone. And then you come into one of our offices, and I want to talk about, well, you better get clean it's time to, clean up your act. It's time to, and many people aren't ready to hear that, because when they're leaving my office, their stomach may still be empty. They haven't seen their children in 2 weeks, or as I'm experiencing right now, the DCF people are trying to remove your children. So these bigger issues, life issues, get in the way of trying to deliver real recovery services always. So, as we say, we must meet them where they're at. How do you meet somebody where they're at when there is no referral for housing? There's nowhere to go. It can be very straining and stressful on coaches and therapists and everybody else. It can be stressful when you just don't have the answer. Thank you.
So true, Lorraine. I was going to add that we work closely with the Northern Ohio Recovery Association, and they've been around for 20 years. I think it's 20 years. And they were actually able to apply for building recovery housing units in their area. So I think it's an example of how these recovery community centers are such central places. They make so many good connections. They build so much goodwill in the community that in the rare cases and the wonderful cases, they're able to do those kinds of things, which is another wonderful way in which they are changing the communities around them. I fully agree, though. Boston is an incredibly hard place for housing. Anyway, it just is an example of what can be done, but what these organizations do beyond everything else they're already doing.
I just wanted to add one thing. While people are struggling and they are in places of crisis. And as Lorraine stated, people come here, they're hungry, they have a lot of legal issues. And so one of the things that we do is we can at least feed them, we can at least help them work through a lot of their legal issues while we are trying to find resources for housing. Even the shelters are full. We try to find sober housing. So we, as Lorraine stated, and we meet them where they are. And so in the meantime, we have to deal with the issues that are, keeping them just keeping them anxious and keeping them fearful and keeping them hopeless. And so coming here, we at least try to give you a safe place to be while we're open. We're open every day but Sunday, and we're open the majority of the day. So at least there is that in the meantime.
Great point. Thank you, Loretta. In the comments here, and everybody just feel free to just speak up or put up your hand. George has raised a question here about who is providing services. George, would you be willing to talk us through your question?
Well, sure. And it really goes back to what was 65% are white service providers and significantly less, and primarily women. So it's about how your study is addressing the issue of what I would describe as underrepresented or underserved populations. Even within those areas that you've studied, are they primarily serving whites? And how does that compare to the geographic distribution of the various subpopulations in those areas? Because that, to me, is one of the biggest challenges that I've seen recovery community organizations face.
I think that's a great question. And, I would say that we have data from 2 additional centers since we prepared this. And I think that there's more diversity than I expected. And so the 65%, I think our final analysis will be a little closer to half and half. So I would say I've been surprised at the diversity when we've done this random sample across US subregions. And I think, and Hannah has been with me, she's here. And Hannah, feel free to chime in if you want to or if you can. But there's been a good bit of diversity. And I've found that the peers that are being served by the peers that are working there are often similar to one another. So we did not ask a specific question about cultural competency. And this is, I don't want to say anecdotal because we just haven't analyzed all the data, but I think you'll find that the final results, there's more equity across different categories than I expected, even in our rural communities, and that many of the peers in the workforce are serving folks that look like them and come from the same neighborhoods. Hannah, you spent time with me in all of these focus groups.
Yeah, I would agree. I think just thinking back on our focus groups, we've seen a lot of different people from a lot of different backgrounds in our thing. And where RCCs are so embedded in their communities, they tend to get people a lot of times that don't have transportation. They're not coming from counties away. So it is a lot of people that are at least residing in the communities where they're in as well.
But I do think that's such an important consideration. And we talk a lot about that in our work here in Northeast Tennessee. Do providers and treatment agencies look like the folks that come through the doors? And do they feel welcome? And especially our sexual and gender minorities. That's been sort of a conversation we're having here as well.
Yeah, and it's really even more so, do they feel like they belong? It's do they feel heard, understood, and respected, as opposed to it's got to be somebody who looks just like me. And that's a hurdle. I'll just say it.
Thank you, George. I agree.
If I can I add just one more thing?
Of
That
course.
sounds interesting. When we're talking about the different types of services that the RCCs provide, there are so many different things being offered, from art therapy to meditation and yoga, and so many things that are crossing different potentially cultural barriers. And there's just so many options that are being provided to reach a variety of backgrounds. And I think that's really interesting too.
And ping pong and video games and oh my goodness, like I feel like they really are not just the new kids on the block, but the cool kids on the block. They want to hang out at RCCs, and I know I saw Dottie here, so she's in my community at an RCC and actually helped pilot test some of our data before we fielded this. And yeah, it's just a cool place to be. I love hanging out there. I saw Dottie's face just for a minute, so yeah, it is really cool.
Totally great. I'm going to go to you next, Nathan. I'm just going to remind folks, and you've seen it, folks have had to log out. We are at the hour. We're going to stop recording at this point, and that's because we usually try to reserve the last half hour for even more kind of conversation. So we will record. Actually, we're not going to stop recording. We're going to keep it going, but we will not publish beyond this time point. So our team is going to review the comments that are coming from now until 1:30, and we're going to summarize them in an anonymous way. Any links you share, we'll put in there so that information is still there, but feel free to speak freely. And that's so that we have this meeting after the meeting. Nathan,